obviously it's dose dependent, and this is why we learn how to use in a better way dopamine agonist. We use very high dose of dopamine agonist. When I started to work as a neurologist, I used 24 milligram of a dopamine agonist called ropinirole. I don't use it anymore. I don't go so high. I barely go up that higher than 12. But because I learned that I can use more efficiently that medication at a lower dose. So this is why you experience no response in the afternoon. Because, and still this is one mistake everybody does. This is a question for you, and raise your hand. Who of you takes their medication in the afternoon before lunch? Okay. Who takes them within 2 hours from lunch? Within. Okay. Who of you take the medication within 1 hour from lunch? Who of you takes this medication after lunch? Okay, thanks. Okay, totally wrong. Okay? Sinemet and Madopar, levodopa, or co-careldopa or co-beneldopa, that is the generic, must be taken on an empty stomach, because otherwise they do not work.
I can't do that.
There are exceptions, okay? There are exceptions, very rare exceptions, because few people, unfortunately, experience side effect of taking on an empty stomach, like this feeling. Yeah. So, but this is very unusual, okay? It's not the rule. If you experience very bad side effect, unfortunately, we say to take on an empty, on a full stomach, but they do not work as well as on an empty stomach. So one of the reasons why in the afternoon your medication might not work very well is because if you have lunch at 1 and you take your medication at 3, still there is food in your stomach, and I will show you one picture of the stomach of my patient, and you find the tablet of Sinemet after 1 night of sleep, still the tablet is there. Obviously, some patients may have a slower stomach than other. Not everybody has low stomach. Again, there is heterogeneity. I have people with Parkinson that they take their medication on a full stomach and they don't mind, but it's not correct. You should learn to take them on an empty stomach.
How far ahead should you take
Okay.
medication?
This is the rule, okay? It's international rule. So you take your medication. It depends if you take your medication 4 times a day, 3 times a day, or 5 times a day. But ideally, you take your medication. You can have breakfast, lunch, dinner, at least after 20 minutes.
Oh, that's
okay? Perfect. But this is not the mistake. The mistake that everybody does is that they have their lunch and then they take their medication after 2 hours. You need to wait 3 hours. This is very difficult when medication are given every 2 hours. I'm against giving the medication every 2 hours. I never give medication every 2 hours. Doesn't make any sense, because there are other medication that I can add on the top of Madopar, Sinemet, co-careldopa, co-beneldopa that prolong the duration. So I don't need to give it every 2 hours. And if I give the medication every 2 hours, the brain gets used to this boost of dopamine. And what happens is that it's very difficult to explain in simple words. I hope I can explain. What happens is that, like dopamine in the brain is recognized. We have receptors to recognize dopamine. It's like, I do say in English, it's like, like the TV.
Antenna.
It's like an antenna, okay? Good, thank you. So it's like an antenna that recognizes the dopamine, okay? If there is too much dopamine, the antenna goes inside the neuron. So there are not enough antenna to recognize. That's why when I see people that is over-medicated, I suggest them to reduce the medication, the frequency of the medication. I say to them, wait for 3 weeks. It's gonna be very difficult 3 weeks, but that after 3 weeks, you're gonna be fine, because the antenna needs 3 weeks to come out. So that's why. So there is a reason, there is a scientific reason to do that. So it's wrong to do that. I hope that at least, but I don't think that some of you takes medication more than 5 times a day. Is there anybody taking medication more than 5 times a day? No, okay, that's fine. This is a very good sign. That means that I'm talking with people that is in the stable phase, okay? But it's good that you know that you might develop some of these symptoms. I think in a very mild form, but if you don't know that you are expected to develop these symptoms, it's very difficult to treat them. Okay, so I will show you now when a patient becomes a candidate for deep brain stimulation. So it becomes a candidate when quality of life is poor. This is the first criteria. Because if quality of life is somewhat good, we don't consider. These are very invasive intervention. It's like a surgery in your brain or like infusion in your stomach. So we don't want to consider invasive options with risks in people that are not candidates. And it's very important, patient motivation and also a supporting partner, a supporting caregiver. Otherwise, it's impossible. And the other concept that if you need this, too far in Parkinson can be too late because you miss the opportunity. If you need when you are 65 and then you're not a candidate maybe at 70 years old, you miss your occasion to have them. Again, we offer them if we think you need them. Which are these therapies? Here they are. This is Duodopa, this is apomorphine infusion, and that is deep brain stimulation. I will show each of them, okay? Again, maybe none of you will need some of this treatment, or some of you might need. We'll see maybe if you can recognize yourself as possible candidates. Let's start with deep brain stimulation. So what you see there, you see a man, and inside the man there is a wire. So deep brain stimulation involves us to put a wire in the brain. And this wire is really powerful because deep brain stimulation is the only treatment that can treat Parkinson's disease for 24 hours a day. And you know also that in Parkinson's disease, symptoms are more on one side of the body. When you take the medication does not know which is the most affected side. It goes to both sides, yeah? And some of the symptoms arise because, some of the problems arise because the medication cannot discriminate. Deep brain stimulation is done in both sides, so we can adjust each side independently. Who are the candidates? So the candidates are those people that have severe off time. So now you know what is severe, what is an off time, very severe. So basically you take your medication, you're doing very well, but in the off time you cannot walk, or you have very severe tremor, or you have difficulty in the night, really your sleep is totally disrupted because you cannot move at all during the night, you have pain, you have cramps. So this is a motivation for deep brain stimulation. We have some rules. We consider those people that have at least 2 hours of off time per day. So if you don't have 2 hours of off time per day, we don't consider. And at least 5 doses of levodopa. I'm being referred many people, and most of my patients ask me about DBS. So I'm a candidate, can I do DBS? Because DBS is seen like, oh my God, this miraculous therapy. It can be a miracle, can be really a miracle, but if the candidate is not suitable, if he's not a good candidate, can be very harmful because people can risk their life, can risk their mobility, and they're not even a candidate. It's really important to be very strict. Really, we in our group, we have set very strict selection criteria. And another indication for DBS, you might lack all of this, but if you have very severe tremor, really very severe, like shaking like this, in all your body district or in the upper limb, that does not respond to medication, we might consider deep brain stimulation in these people. And that is quite effective because I will show you one video, it stops the tremor. There are age limits. I don't operate people older than 70 years old because they don't do very well. DBS have better benefit in people that is younger. You need to have normal cognitive features. So if your cognition, if you have some memory problem, I mean like a major memory problem, you are not a candidate. If there are hallucination, you are not a candidate. Obviously, if you experience hallucination because you are on a very high dose of medication, we might consider it because those are hallucination due to medication, and then your brain scan must be normal. So it's very strict. Just 10% of people fit into that. And as I told you, it's good selection, good outcome. What we do, this is the wire. See, the wire is coming, yes? And this wire has 4 contacts, 4 sites of stimulation, and there are different types, different sites of the stimulation. Most of the subjects have DBS in the subthalamic nucleus here, and this is this right spot in the brain is very deep. In Parkinson is very hyperactive, and being hyperactive with this electric current, we can normalize the hyperactivity. Most people think, okay, it's just the surgery, I just go for surgery and then it's gonna be fine. No, surgery is just the first step, but the most complicated step is on the neurologist. So as a neurologist, I am in charge of regulating the system. So this is a brain pacemaker, you know, like there is a heart pacemaker for the heart. This is a pacemaker for the brain, and I need to set carefully different parameters. So where to stimulate, how much, which frequency. There are guidelines for that, so you don't do you don't do it by chance, otherwise it would be a disaster. So other thing is that most people ask me, is DBS lasting forever, the effect on DBS? DBS have a main advantage. It treats motor fluctuation wearing off very well. So that lasts forever. I would say the longest patient that I have seen in my life with DBS at 25 years of DBS. And if the surgery is well performed, the effect is still there. Obviously, Parkinson progress, so there are balance disorder and gait disorder that can arise over time, and that's why we shouldn't delay too much the DBS. But the effect on the fluctuations, on the wearing off, that lasts. The effect on the sleep, most people that cannot sleep before DBS, they really can sleep again after DBS. I don't want to sell you like a miracle treatment because, again, it can be a very powerful one, but it's not for everybody. It's important to know that there is this possibility. Why DBS is unique? It's the only treatment of Parkinson that allows to reduce the medication. I had treated people that took 12, 15 tablets per day. Now they take 4 tablets per day. So this is a good thing because obviously taking the medication all the time, like all over again, is not really a good life, and they cannot even improve your symptom. As I told you, we can fine tuning each side of the brain, and then the night symptom improve very much with DBS. I show you a few cases. Okay, so this is my patient. This is a video. It just had freezing of gait. This is before DBS, and this is after DBS, and this is the off time. And in that video, it's not taking medication. So when it works well, it really works well. There are good selection is important, good surgeon, and good neurologist. You need a team. Cannot be done like this because it's really very helpful. I show you a patient with tremor. So this is a reason why it's not working. Yeah. So here she's crying because she had very severe tremors because I stopped the stimulation. And here is the same day. Oh, sorry. There is no tremor. So this is off and that is on. So you see the effect of the tremor. It's really quiet. And you see this is the device, and I'm just turning on. I turn on, and the tremor stop. So the effect on the tremor can be really very strong and very effective. This is another patient, and this is a patient that had dyskinesia. As I told you, this patient was taking so much medication because he was also addicted to medication. And here, this is off, and this is when the device is on. And there are no dyskinesia at all. So I think that is quite convincing in that. But there are buts. there are side effects, and there is a risk of bleeding that is less than 2%, but is there. There is a risk of infection of the system. There is it is always very low. It's also less than 2%. There is the risk that the system break, because this is an electrical system, but we are a kind of electrician, so we can replace the system. The most harmful complications are the bleeding and the infection, because also the pacemaker can get infected also after many years. For example, if there is a trauma, it happened to a patient of mine that he hit his head and he had the trauma very close to the electrode entry point, and we needed to replace. We had to do again. It's not like the bleeding, because the bleeding really can be very, very disabling. Other example of DBS. Remember, that was the patient with the freezing of gait. She had the freezing of gait in the wearing off. This is before DBS, that is after DBS. But again, be careful, because not always freezing of gait can improve with DBS. This is a patient treated with DBS that actually had severe freezing of gait despite DBS. And as I told you, freezing of gait can be resistant to medication. So we can consider DBS for freezing of gait if freezing of gait responds to medication. Otherwise, we don't consider. Now I finished talking about infusion therapies, and infusion therapies are apomorphine and duodopa. So duodopa, I will explain what it is later. So this is the apomorphine. Apomorphine was introduced in UK, that's why it's popular here. It's still one of the countries where it's done very, very frequently. And again, the criteria is always the same. Age is not an issue, so can be considered also in older people, but cognitive impairment is an issue. But if you have some problem in your brain, reduced volume of your brain is not a contraindication.